Have you ever noticed that two patients with the same blood pressure can be started on completely different drugs, and both prescriptions are correct? And have you ever wondered why some blood pressure drugs are called first line, while others are not, even though they all lower BP? This is where many students get confused. They try to memorize drug lists instead of understanding the logic behind treatment. And that confusion shows up in exams and in real clinical decisions. Let's fix that. Not every blood pressure drug is first-line therapy. Choosing the right starting drug depends on evidence, patient characteristics, and the dominant mechanism causing the hypertension. For most patients with uncomplicated hypertension, thiazide diuretics are first-line drugs. Why? Initially, they lower blood pressure by reducing blood volume through increased sodium and water excretion. But long-term, their most important effect is reducing peripheral vascular resistance. They are effective, affordable, widely available, and generally well-tolerated. That is why guidelines consistently recommend thiazides as a first choice. ACE inhibitors and ARBs are also first-line options, but in specific patient groups. They are especially useful in patients with diabetes, chronic kidney disease, or heart failure. These drugs don't just lower blood pressure. They protect the kidneys by reducing intraglomerular pressure. They protect the heart by reducing remodeling and workload. So when organ protection is a priority, ACE inhibitors or ARBs become the smarter first choice. Calcium channel blockers are another major first-line option. They are particularly effective in older patients and in Black patients. Why? Because in these groups, hypertension is often driven by increased peripheral vascular resistance rather than fluid overload or renin activation. Calcium channel blockers relax vascular smooth muscle directly, making them very effective in this setting. Now let's talk about beta blockers, because this is where many people make mistakes. Beta blockers are no longer first-line drugs for uncomplicated hypertension. Not because they don't work, but because they do not reduce stroke risk as effectively as other classes in these patients. However, beta blockers are extremely valuable when there are specific indications. Patients with heart failure, patients with angina, patients who have had a myocardial infarction. In these cases, beta blockers are not optional. They are essential. Another key truth you must understand is this: most patients will eventually need more than one drug. Hypertension is rarely controlled with monotherapy alone. Using drugs with different mechanisms, for example, a diuretic plus an ACE inhibitor or a calcium channel blocker plus an ARB, provides better blood pressure control with fewer side effects than pushing one drug to the maximum dose. So the real goal is not to memorize drug names. The goal is to understand the patient in front of you. What is driving their hypertension? What organs are at risk? What benefit do they need beyond blood pressure reduction? When you think this way, hypertension treatment becomes logical, it becomes safer, and it becomes effective. If this explanation finally made first-line hypertension drugs make sense, like this video, share it, and subscribe to Elite Medic Nexus. Turn on the notification bell so you don't miss upcoming lessons. Check out our full long video on hypertension medications for a complete step-by-step breakdown of every drug class. And stay tuned, because in the next video, I'll show you exactly how to combine these drugs safely in real patients so you never get confused again.